Welcome to the second webinar of the Alberta Futures Policy Program, Transforming to Integrated Community-Based Services for Older Albertans. I'm Sharon Anderson. I'm Secretary of the AAG Board and Research Coordinator at the University of Alberta in the Department of Family Medicine. So the Alberta-based Association on Gerontology is a member-based organization focused on advocacy of policies for the future of healthy aging and quality of life for older adults. AAG members come from across Alberta: older adults, caregivers, care providers, organizations, educators, researchers, and students. And we're pleased to sponsor the AAG Policy Forum program with a number of initiatives to foster culture and community change for the support of a healthy aging vision for Alberta and opportunities for transformation of systems and services. So please check us out on our website, albertaaging.ca. First, I'd like to do the land acknowledgement. The Alberta Association on Gerontology acknowledges its presence on the lands of the Indigenous peoples across Alberta, and we're committed to ongoing dialogue and shared learning to achieve healthy aging and quality of life for older Albertans. And here I'd like to introduce Irene Martin-Lindsay from ASHA, the Alberta Seniors and Community Housing Association, and she's just off of their big conference last week. Irene.
Hi, everyone. I'm really pleased to be here today. The primary purpose of ASHA is to provide member services and a bold, unifying voice to support providers of seniors and community housing. Our members are over 100 organizations that serve over 60,000 Albertans with their housing and support needs. And I was asked to talk a little about why it was important for us to sponsor, and it's because we all know we can do better in supporting our aging population. And so, guided by our principled position, our principled positions, which are living well in community, a strong housing focus, and really honoring person-directed choice, we can strengthen our collective advocacy together. And we think there's strong alignment between the work of the Alberta Association on Gerontology and our noble cause, which is to create a world where Albertans live in housing that honors their dignity, serves their needs, and inspires purpose in their chosen community. We're really happy to be here, with you today, and look forward to, working to strengthen our, advocacy to transform the system.
Thank you very much, Irene. Now, before I introduce the speakers, I just want to provide some context on older Albertans and why this webinar on community-based services is important. So according to the 2021 census, which was just released, there are 629,220 Albertans 65 years of age and older, 14.8% of our population. And just for context, because here is talking from BC, BC has 21% of their population are seniors, so more than Alberta's, and the UK's, because Dr. Essam is talking today too, the population is 18.5% of their population that's over 65. This graphic comes from the Alberta Health MNP Improving the Quality of Life of Residents and Facility-Based Continuing Care report. There's 3 layers of policy to achieve healthy aging. So the last webinar focused on long-term care. So that's level 3 here at the bottom. And 6.8% of Albertans over 65 reside in seniors residence, and that rises to 30% of those who are over 85 years of age. Assistant Deputy Minister Evan Romanow spoke about the new Continuing Care Act, that's Bill 11, and that's going to include home care, this level 2 complex care provided at home and in the community. And today we're going to focus on healthy aging for the 93% of Albertans who live in the community. So connecting housing, healthcare, primary care, community services for healthy aging. I just want to, it's important to note, of those living in the community, 29% have moderately complex conditions and 17% have very complex medical conditions. And at this point, I'm going to introduce all three speakers, and then Dr. Essam is going to kick us off, but I'm just really pleased to introduce these speakers. Dr. Marianne Essam. Dr. Essam is a general practitioner in the UK, and she's been a general practitioner for over 30 years, and she's ambassador for social prescribing. Social prescribing is a practice of medical practitioners connecting patients to community supports to improve health and well-being, and it was pioneered in the UK, and it's now gaining a foothold in Canada. The UK is investing in link workers, social prescribers in all of their new primary care networks. And second is Kahir Lalji. Together with community agencies, local, provincial, and federal governments, and a diverse set of vested partners and donors, Kahir leads the United Way British Columbia Healthy Aging team in connecting healthy, inclusive communities. And I just want to talk about the list of things that they're doing for seniors. They deliver the programs called Better at Home, Active Aging, Social Prescribing, Therapeutic Activation Programs for Seniors, Family and Friends and Caregivers Support, Safe Seniors, Strong Communities, Community Sector and Development Initiatives such as Healthy Aging Core, and the project Impact, as Kahir says. Simply put, we are establishing an integrated and supportive seniors health network that can respond to individual community needs and that can support seniors' independence, resilience, and social connectedness. And our third speaker is Karen Mcdonald. And Karen, I know Karen as the Executive Director of the Sage Seniors Association and a mover and shaker within Alberta. Karen acts as the chair of Healthy Aging Alberta, which is seeking to create a provincial network of organizations that are united by a shared vision. We want Alberta to be one of the best places in the world to grow old. And with that, I'm going to stop sharing, and I'm going to introduce Dr. Marianne Essam, and she's going to tell us about her experience as a social prescriber, an ambassador for social prescribing, and a general practitioner, and how that works in the UK. So Dr. Essam.
Thank you so much, and thank you for the honour of including me in your social prescribing journey in Canada. It really is an enormous privilege. And yes, in the UK, we've been running with social prescribing now for about 10 years, and it is gaining tremendous momentum, not least because having discovered how good it is, we've got to keep doing it. So really, I'm going to try and explain a bit of our journey and why we are so excited about it and why we are investing in it, and how it is changing the way that we view health, how it's enabling us to embrace the social health determinants and make them priorities in the way that we approach individuals, and how it is taking pressure off the biomedical services. The NHS was, the National Health Service was set up about 1948, when actually there were far fewer diseases even available. Now there's an awful lot of illness to be managed in our healthcare system, and actually it is swamped. But what we came to realize was a good 20% at least of the problems presenting in primary care didn't fundamentally have a medical basis. We also realized about 10 years ago that a lot of problems were generated by the fact that our system was far from integrated. Secondary care, primary care, community services, voluntary sector services, different services for different age groups, different services within age groups, with different other criteria, all very bitty. And we realized that a lot of people were falling down in between the chasms between these organizations, wasting a lot of time, getting sicker, losing hope, losing any sense of trust in the system, just feeling just increasingly despairing and becoming increasingly expensive. So this wasn't really very sustainable. And the other thing was health and social care didn't often have conversations. In fact, there was a quiet enmity between the two departments. And as for the voluntary sector, lots of good things there, but they didn't speak to each other either. In fact, you'd even see in meetings them hiding their sheets of paper that they were scribbling good ideas on in case somebody stole a good idea and had a funding advantage. So you had this system that rather than sharing ideas and resources, we were just driving people into their separate corners. And the people that were suffering were the patients and their carers and their families. And we were wasting a lot of money in the process. So we had this great initiative from the UK government called the Better Care Fund. And they suggested that both health and social care should put into a piggy bank as much money as they were brave enough to do so, and use that combined piggy bank to pay for something that started integrating the disintegration around the people that needed it most. So we kind of drew out the system and mapped all the gaps and realized if we had a workforce that worked in the gaps on behalf of people, we would go some way to solving this chaos. So we started to invent our local social prescribing workforce, not realizing that's what we were inventing. We were just inventing what we thought we needed. And because there weren't a lot of fixed criteria to this piggy bank, we were able to be creative and innovative and collaborative and get stakeholders together and start to explore the options. We wanted to mess up the boundaries so that nobody said, this is a health initiative, this is a social care initiative, this is a local authority initiative. We wanted it to be an initiative that everybody owned and that worked for people. And we got third sector organizations to agree to collaborate to host these workers, and we managed them by an individual that was paid part by health and part by social care. So you see, we deliberately messed it all up. People stopped using the health, social, voluntary sector language and started talking about what we called community navigators. Within a year, we realized that this same kind of phenomenon was cropping up all over the country, not just through Better Care Fund, but actually everybody realizing that this was crazy and could be simply solved. And so we joined forces together more as a social movement than any initiative or policy. But within the next 4 years, the NHS had realized this was good news and had made it policy and started working on a service specification for link workers, as they chose to call them, that would actually be attached to primary care directly rather than just floating in between. And so we've been on a journey over these last 6 years of starting to develop that workforce within primary care, as well as building it up within the local hospital and within all of the community organizations, so that we've got a tremendous sense of creative collaboration. We're driving up social capital. We're having conversations amidst our complex adaptive system, which is far more of a system than ever it was before. And we are reaching people at a point before a crisis far more often. And when people are in a crisis, we're able to unpick things and identify where some of that crisis is socially or economically or environmentally determined rather than being a biomedical clinical problem, therefore shifting it away from the doctors and the nurses into the right kind of hands who are becoming respected and trusted as an incredible resource. Obviously, there's other work behind the scenes in terms of collating a database of the community organisations and advice and grants, etc., that are available for these link workers to draw on as they meet with individuals and build a personalised care plan, identifying the ambitions, the unfulfilled goals and dreams at whatever age, and looking to see where the obstacles and the blocks are that could be solved so that somebody has a much sweeter journey through the rest of their lives. And this is a work in progress, but it's happened pretty fast. And I'd say that social prescribing has been the thing that has made our government realise that rather than looking at propping up health services and keep spending all the money on the A&E departments, we need to invest in a personalised health approach which embraces all of the other aforementioned aspects. I'm going to tell you a couple of stories which I hope will bring it to life, because this is the key thing about social prescribing. When you realise how different it is from everything we've historically done, you will want it. You will want to build it. You want more of it. You will want to include more organisations in it. And you will reach, as we have, a point of no return, because this is the new being well. This is the new regaining hope where despair had set in. This is the new connection where isolation had occurred. And this is an opportunity to build people capital, involving people in volunteering in the very services that their neighbours actually need to access. So on every possible level, it is a win. We had a gentleman who had been to accident and emergency 8 times with crushing central chest pain. Now, you must go to A&E if you get crushing central chest pain. And he'd spent a minimum of 6 hours there every time, clock ticking, as a blood test that always takes 4 hours to come back. And after 4 hours, our hospitals have to admit them or they get charged an extra bit of money. You know, it's all money, money, money. Tick, 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 tick. And this poor man, so anxious, waiting to be reassured, sent home. No, you haven't had a heart attack. He did, however, have quite advanced Parkinson's and was disabled and just worn down and worried. And we sent home with him one of the link workers from what we call the integrated discharge team. We have them in there. And she said, look, I'm not a doctor, I'm not a nurse. If you get chest pain like that, you go off to hospital. You must do that. And you call an ambulance to get there. However, can I get to know you? And maybe I can understand, is there any pattern that leads to this, given that you've had a clean cardiac bill of health 8 times now? Is there anything that I could maybe understand about your situation that I might, as a non-medical person, be able to help you with? So she identified, I think it was about 8 different things that made him really anxious. And actually, it was anxiety that was triggering the chest pain. Some of those things were like needing transport to get to outpatients departments. That was organised via voluntary transport. Some of it was grab rails and different aids around the house to make it less likely that he'd fall and stumble as he moved from A to B. That was doable. Some of it was how to manage that feeling of anxiety when it mounts. That's also doable through a referral to our wellbeing team. And so she was gradually ticking off different aspects, and his anxiety levels were starting to go down in the conversation. And he breathed a sigh, and he, having reached a point that he thought, perhaps I can trust this lady, he said, and you see that old settee over there, that old sofa? Well, my wife and I, we used to sit in that together and hold hands, and well, whatever happened, we'd get through together. because we'd sit there and we got each other and life's going to be okay. Neither she or I can get in or out of that sofa anymore. We're too decrepit. So we sit on dining room chairs on opposite sides of the room and we worry at each other. Social prescribing link worker acquired a philanthropic pot of money to buy a new sofa into which they could get both in and out, and they could sit there and hold hands again. This gentleman has not been back to hospital. So this is the kind of out of the box thinking that makes a radical difference to that couple. You know, and you wouldn't be asking questions like that when they arrive in A&E, but that was the very thing that made the difference. Another lady kept coming in with pneumonia with no underlying respiratory condition, and they thought, what is going on here? Sent the social prescribing link worker back, discovered 3 of her windows had missing panes of glass. Nobody had thought to ask her, what about the temperature of your house? And she was too embarrassed to say, actually, I need some glass in my windows. Relatively simply solved, has not had pneumonia since. You know, people that are isolated, that are facing disability, but have got ability that they could use if they thought a bit differently. All of these people are finding a social prescribing relationship is transforming the way they look at their lives. And social prescribing repositions them such that they're in a place of can do rather than what I can't do. And we're joining the dots around people. And sincerely, even special groups like veterans and carers, different people who have been bereaved, for instance, through the pandemic, reaching out to groups, starting to use social prescribing as a population health management tool, but one unique and precious individual at a time. It has to be individual, but you can start seeing how you can scale this up and start reaching out to groups that you know are vulnerable. So as I say, in the community, in the hospitals, in primary care, it is now kind of the word on the street that doctors don't just think about medical things. They're interested in the rest. Not that they're going to solve your problems, but they have trusted colleagues who they work alongside. And it's a big journey because we've got to change the mindset of very medical thinkers into embracing that. And we've got to continue to encourage communities to collaborate. We've got to look at the whole perverse incentives of the way money moves in our system, which doesn't always do the sensible things, and policy change and looking at how things are funded, how voluntary sector is funded, how voluntary sector is helped towards good governance so that they are robust organizations. All of that is still a work in progress and will be essential to the sustainability of social prescribing, because you need places to be able to introduce your people to, community groups and advice and grants, etc. You need all of that. A colleague of mine says, if you think of the link workers as travel agents, you need plenty of holidays to be able to send them on. So therefore, funding your third sector and your community, building that up and making that sustainable is a pivotal part. Also, managing the capacity and the workload of the individuals that are working in the system is a very important part, because as it becomes popular, we flood it with referrals. The government have, in their wisdom, given us targets to reach for a number of referrals per head of population in primary care. And that actually currently outstrips the capacity that we have in our link workers. So we are still very much on a journey to get this right, so that authentic, personalized, transformative social prescribing is available to everybody in our communities that need it. It is an absolute win-win for the aging and, in fact, for every age group. My vision is cradle to grave social prescribing, because it is the right approach to most people's situations. The medicine will always be important. it will also always be the most expensive. So let us invest in the wider health offer and mobilize one another and our communities to get social prescribing going all over the world. Thank you. I've used 17 minutes. We've got about 2.5 left for questions overtly, and then I'll go into the chat.
So Cahir is, with that, Cahir is going to, we're going to let you have some supper here, Dr. Essam. Cahir, without further ado, let's hear about what BC is doing.
Thanks, Sharon. First of all, ditto, ditto, ditto to everything Dr. Essam just said. And for those that don't know, about 5 years ago, I had the distinct honor of visiting the United Kingdom, met with the National Health Services to learn about social prescribing at their conference. I was so inspired. I came back, I talked to our provincial government and said, we got to do this. It's the only way forward. And so I want to acknowledge Dr. Essam and all of the work that's been done in the United Kingdom to what I would say are global pioneers and leaders in this work, in working towards an integrated system of support for all people. So I just wanted to start off with that, and I will do my best to follow that remarkable presentation. Look, here in British Columbia, we know that 1 in 4 older people do not have somebody to call if they were facing a crisis or emergency. We also know that one of the reasons that older people are malnourished is because they don't want to eat alone. We also know, and speaking with a number of physicians, that the number of failure to thrive that are on ER records is because older people wanted a physical human contact. And so when we talk about a person-centered approach, when we talk about meeting people where they're at, it is important for the continuum of care to come together to make sure that individual is really at the center of support, both for the quality of life of the individual, but also, as you'll see, as a way to help support our healthcare systems. You know, when people talk about a tsunami of older people and the risk that it has on our systems, I don't believe in that. I believe our systems and the way it's created is our own barrier, not the people receiving services. So today I'm going to talk a little bit about the role that community-based organizations can play in supporting older people, their family, friends, and caregivers to age at home and access the supports that they require to live healthy, dignified lives. I will set the context, though, that the work that's been done in British Columbia in social prescribing and other investments are focused on older people. And, you know, I want to acknowledge that there are different models that exist around this work, but for our intents and purposes, our audience base are older people. I would also say that in a very informal way, social prescribing has existed in our country. We just haven't called it that. And the way it shows up, the way it looks, I think you'll see resonates. But there's a call to action here. And the call to action is to resource this work, 1, to better integrate our systems of support, but 2, to also ensure that older people have the right to choose what services and supports they need in order to live safe, happy, independent, and dignified lives. We work with over 700 nonprofits in British Columbia. And so I want to acknowledge the collective unceded and ancestral territories that all of our work is done on in British Columbia. And so I just want to pay homage and respect to the unceded and ancestral territories. A lot of the work that we do stemmed from a 2017 summit on aging, where nonprofits who were serving seniors said, we need to be recognized the profile of our work needs to be enhanced, and we need to be a collective, united sector to have a collective voice. At that time, we came up with this concept, community-based senior services sector, so CBSS, and I'll be referring to this throughout the next few minutes. And when I talk about the community-based senior services sector, I'm talking about all nonprofit and local government services, including rec centers, community centers, multi-service agencies that provide asset-based, community-based programming to older people in their communities. So when we started to look at the strategy and how to mobilize support for this work, there were some key considerations that we took into account. Number one, that this needs to be driven by community. Community knows what they need the most, and this would need to inform and drive the work that we do. We also know that there was an uneven support for older people, people that have been traditionally underserved and underrepresented were disproportionately impacted by social determinants of health and access to resources. So newcomers, displaced peoples, elders, those that identify as LGBTQ2SI, those that are blind, those that are culturally deaf and hard of hearing. There were certain underserved and underrepresented groups, those that lived in rural and remote BC, that needed particular and intentional support. We also did a scan of promising practices, including social prescribing from the United Kingdom, as well as other innovative evidence-based approaches. We also knew that collaboration was instrumental to the success of this work. And we also knew we had to overcome this competition and fragmentation in the sector, both within the community-based sector and amongst the health and community-based sector. And you hear Dr. Essam speak a little bit about this. So we needed to find a balance to ensure that the individual was at the center of the work, but we also needed to do this in a way that maximized efficiencies. We know the cost of living at home is far less than the cost of healthcare utilization. And so we needed to bridge these two concepts to be able to mobilize a coordinated system of support. In our community-based model, at the epicenter of our work are older British Columbians, their family, friends, and caregivers. Surrounding that nucleus is community, in whatever way one defines community. Geographically, a community defined by a group of people that have shared experiences of oppression, a shared value belief system. There is a community that surrounds the individual person. We layer this here in BC to say, supporting healthy, caring, inclusive communities are local community-based service providers. Over close to 1,000 in BC, of which we work with about 700 of, that are instrumental in supporting the development and the coming together of community. Work that has often been under-profiled and the impact it has on the trajectory of one's lifespan. We also knew we needed a level of coordination. And so in conversations in 2017, United Way British Columbia created a healthy aging department and acted as the provincial backbone to the community-based services sector in British Columbia. And what this did, it allowed us as a collective voice to speak to policymakers, to funders, to different levels of government around the needs in community. And the work that we do, again, is driven by a community-based model, but is really upstream and prevention-based. We know that there is an increasing number of older people living in community that fall within a gap here. And the gap is those that don't qualify for publicly funded support, yet don't have the resources or the capacity to participate in programs. And so this gap of supports for frail and pre-frail elderly was the focus of the work that we developed here in British Columbia. I wanted to share this diagram because it illustrates the provincial reach. So the center there of green where you see no programs is uninhabitable land in British Columbia. But really the intent here is whether you live in a northern community of 298 people, or whether you live in a larger metropolitan area, loneliness, access to culturally appropriate food, to transportation, are all social determinants of health that fundamentally impact one's quality of life, regardless where you live. And so this idea of people deciding to live in risk or needing to move to access resources doesn't particularly resonate with us, because we need to meet people where they're at. We need to support people to age at home where they wish to age, as long as they wish to do so. And so for us, it was important to take programming to community rather than put the burden on older people, often who have challenges navigating systems, just like we do, to be honest. And so really bringing programs to community. So social prescribing was one of the key pieces of work that we endeavored to undertake. We looked at different models across the country and the world, and we added our particular flavor based on the nuances here in British Columbia. Number one, we worked with our health authorities and primary care providers, saying, you need to partner with the community-based sector to make this work. We embedded social prescribing in the community-based nonprofit sector. So we have a link worker where we fund community-based organizations to hire a link worker to play the similar role that the worker does in the UK, and it's to work with primary care providers and work with older people to support access to services that would enhance their quality of life, whether that's gardening, a walk in nature, whether it's a friendly coffee chat, whether it's access to a hot meal, whatever service that older person required, it's this link worker's responsibility to facilitate that referral. And we approached this model because we felt that it's one thing to refer older people to programs and services, but what we found was some people needed extra support in navigating programs, in navigating services, and making that initial connect to programs and services. And so this is why our model is based in the community-based services sector, in partnership with the primary care providers in their community. Look, all of this work that we do needs to be supported by what we call learning and monitoring. We don't really use the word evaluation because it has some oppressive connotations to it. So we like to learn from our investments. And so we had a four-pronged approach to how we were supporting our learning of the program. One is looking at healthcare utilization by people that were receiving social prescribing services. By being a participant in a social prescribing program, did it lead to a reduction of emergency room visits, visits to their physicians, etc.? Two is a summative evaluation of the program done by a third-party evaluator to go in to talk to older people, to talk to family, friends, and caregivers, to talk to organizations, to talk to primary care providers to understand the impact and the service delivery model enhancements of the program. The third, and I think probably the most fruitful part of this, was a formative evaluation where we bring our link workers together on an ongoing frequent cadence to be able to learn week after week, month after month around how this work needs to shift and adapt. And we wanted to build in inherent nimbleness because we as people are not static. We as people are dynamic, and our program needed to be built to meet the evolving needs of people, but the evolving needs of our surrounding landscapes as well. So here are some findings, and these are some preliminary findings in our summative and formative evaluation. Number one, that social prescribing enhanced people's access to food security, as well as it strengthened vital connections and social connections amongst older people. Two, by participating in group physical activity, people have said that they feel seen, they feel heard, and it's enhanced their overall mental health. It's also enhanced one's sense of social connectedness. The fourth finding was really interesting to us because it really spoke to the upstream preventative nature of this program. Link workers, older people, their family, friends, and caregivers said, this link worker was able to identify early symptoms of potentially acute chronic illnesses that, if left unaddressed, would have escalated to a point where one, the individual's life would have been significantly compromised, and two, they would become reliant on healthcare utilization. So the early intervention, the early identification was also a key finding in some of our preliminary work here. Look, Louisa is one of hundreds of older people that we know have benefited from a link worker, have benefited from local community programs and services. I often share a story about an older person that I visited in a very rural community up in northern British Columbia, who was in her mid-90s, and her son in her mid-70s lived in an outhouse attached on her land. And, they were very, very averse for anybody visiting them. I had the honor to go in and visit her, and she had spina bifida. So she was hunched over and she had tied up a number of wired hangers to get her clothes out of the dryer. She had not left her house in over 10 years. Long story short, we introduced her to a link worker to the community-based program in that rural community. She is now teaching yoga in her mid-90s 3 times a week at the local community senior center. This is the impact of community. This is the impact of meeting people where they're at. We know that the last couple of years has seen climate injustices that have disproportionately impacted older people. We know that there are hundreds of preventable deaths in the heat dome here in BC. I would say, however, those number of deaths would have been far more if it wasn't the community-based organizations that took water to older people's homes, took them to cooling centers. During the fires and floods, it was the local community-based organizations that transported older people in and out of their communities, make sure that they had food, made sure that they were being checked upon. And this is the value of collaboration and a person-centered approach. Look, there are in our experience, 5 critical success factors to making this happen. 1, we need resource allocation of people and funding to make this happen. 2, we have to work in collaboration with other partners, specifically primary care providers, to make this happen. We also need to do this in a way that we understand that we cannot be downloading services to the community-based sector. The community-based sector needs to be resourced to be able to do this work, which we have seen has ultimate cost savings to the system. We need to be intentional in service distribution so that those that are underserved and underrepresented also have the same access to services. And we need to be aligned in the work that we do. aligned in the idea that social determinants of health are so, so important. I'll end with saying, look, the work continues. We're continuing to convene nationally, doing some mapping of social prescribing programming. We're continuing to learn and scale out. We're looking at policy, research, and embedding this type of work in curriculum so that medical students that come out of the system are aware of this work right at the outset, and along with other partners, continue to provide awareness around the value that social prescribing brings. With that, I'll hand it back to you, Sharon.
Oh, thank you very much. This is when we looked at the McKinnon report, the Blue Ribbon report, they compared BC to Alberta and how Alberta's costs were higher. This is the reason, part of the reason why that is happening, because you've got those social determinants of health. And now I'd like to, so thank you very much. Now, Karen Mcdonald is going to talk about what's happening here in Alberta, because how do we make those changes?
Thank you, Sharon. This is a tough act to follow, but how inspiring and exciting. And I hope everybody on the call today is equally excited to talk a little bit about what's possible here in Alberta. Thank you so much for inviting me to share about healthy aging Alberta. I want to acknowledge the important work of the many, many volunteers who give of their time and talents to make the Alberta Association on Gerontology such an important part of the fabric of our community in Alberta. So thank you to Sharon and others that are on the call today. My name is Karen, and I'm the chair of the Community Leadership Council that leads this initiative. So that's why I'm here today. And I appreciate the opportunity to share more about how Healthy Aging Alberta is transforming community-based senior services to an integrated system inspired by the work of our colleagues today. Thank you to Sharon and Kahir for sharing land acknowledgements. I want to acknowledge that I'm joining today from Edmonton, which is located on the traditional lands of the people of Treaty 6 territory and the Métis Nation of Alberta Region 4. And I'm grateful for the traditional knowledge keepers and elders who are with us today and those who have gone before us. I acknowledge that some of you might not know a lot about Healthy Aging Alberta, and so I'd like to start with a quick overview before diving into sharing some updates with you about this work. Healthy Aging Alberta is a collective impact initiative that seeks to bring together social sector collaboration, coordination, and integration. This large-scale initiative is a coordinated effort involving partners from multiple sectors, community, government, and private sector, working together to address complex social issues and leverage the many assets in our community that make Alberta a unique and special place. You're going to hear a lot of parallels to the work that's happening in the UK and in BC. We're just earlier along in our journey, and hopefully we're headed in the same direction. Let's talk about what the initiative is seeking to address. So I'm not going to be quite as, I think, passionate maybe in my articulation of the challenges, but when you see those bubbles on the screen, I hear Dr. Essam's voice in my head. There's so many parallels to the way you beautifully described some of the challenges that social prescribing was working to address in the UK. It's so similar in our work here in Alberta. Organizations serving older adults play a critical role in Albertans aging in their homes and in community. Coordinating our efforts is a key step in meeting the needs of the growing demographics of older Albertans. I'd like to start with the context and challenges, many of which this audience, of course, is familiar with. As you know, the population of seniors in Alberta continues to grow faster than any other age group, and older adults in Canada overwhelmingly express a desire to stay in their own homes and in their communities as they age. Unfortunately, many seniors can struggle to age in place and continue to live in their communities, not necessarily because of the need for medical services, but because of a lack of reliable, accessible, and coordinated non-medical supports. These non-medical supports, such as assisted transportation, homemaking, caregiving supports, service navigation, social connections, and financial supports, are offered less consistently and equitably across Alberta. Access to community supports means seniors can stay more active and have more opportunities to maintain and make new social networks, which is, of course, critical to all of our physical and mental well-being and essential to keeping our independence as we grow older. There are hundreds of community organizations doing excellent work in Alberta, supporting seniors and offering critical services that support healthy aging. Unfortunately, there's currently very little integration among these services or with other sectors such as health and housing. The community-based sector is not currently well-resourced or integrated into the larger senior system of care in our province. This lack of provincial coordination, working in isolated clusters, and the lack of sustainable resourcing for the sector means an adequate community-based service delivery. Preventative community-based care is in fact the solution that will allow older adults to thrive while aging in place and improve their health and social outcomes, which in turn, of course, reduces health system costs and utilization. We've heard some great evidence of that today from our colleagues who are further ahead in this journey than we are here in Alberta. And Dr. Essam really highlighted some things that are not necessarily on this slide that I just wanted to mention quickly. Things like workforce planning, cross-ministerial work, competition for funding, the right provider at the right time, and the respect and trust for community-based services and supporting seniors to live their best lives possible as the senior defines it. Those are all key things that we need to work towards as a sector and as a community. So just wanted to quickly mention those things as well. They're not all on here. We're going to add those to the slide for the next presentation. In 2019, a group of senior serving organizations recognized the challenges stemming from a lack of provincial coordination among community-based senior serving organizations. Of critical importance is the co-creation approach with our allies at the Ministry of Seniors and Housing in the Government of Alberta. It has been one of the essential factors of success in this initiative that we are very intentional to continue to nurture and foster as the initiative grows and becomes more complex. The concept of sector development and what is possible in Alberta was inspired by the success of our colleagues in BC and in the UK, of course, but very much in BC because there's many parallels in terms of our experiences. And the work of the United Way of BC is a backbone for that work. Out of the provincial community consultation process, the What We Heard report was developed here in Alberta, capturing the sector challenges and strengths and the top drivers for collaboration, and a roadmap for developing the sector was released. The report was released in early 2020, but like many projects initiated around this time, the pandemic necessitated quick shifts. It seems like such a minor way of describing what happened, really. The original thoughtful community development approach envisioned was delayed in favor of pandemic response, and the need for community-based senior serving organizations to effectively communicate, share knowledge, and collaborate was heightened. And this is when Healthy Aging Core Alberta was formed. We'll tell you a little bit more about where that's at. Since 2020, the work has grown quickly and broadly. The community came together in the spring of 2021 and helped brand this initiative, Healthy Aging Alberta. Community-based senior services sector is a bit of a mouthful, so we now refer to it as Healthy Aging Alberta. Regional community activation sessions were held in June of 2021, and more than 350 sector members and system allies from across Alberta attended those sessions. Hopefully some of you were in attendance. Overall, Healthy Aging Alberta is a by community for community provincial initiative. You would have heard Kahir say very similar things about the work in BC. It brings together a rich network of community-based organizations from across the province that are united by a vision of making Alberta one of the best places in the world to grow older. With this in mind, let's talk a little bit about our vision for the future. So guiding this work are some principles that unite us. Very quickly, the initiative is collaborative, community-driven, diverse and inclusive. Kahir did an excellent job of highlighting the importance of representing the diverse needs of seniors in this work. Flexible and dynamic, and at the center of this work is always seniors and is action-oriented. With these principles guiding and uniting this work, let's look at some of the initiatives' approaches to the work. We all know that we are always stronger together and that we want to remove barriers to participation and engagement. The purpose of this work is to unify the sector around a shared vision and framework for action and to have a louder, more unified voice. We hope to contribute to the bedrock for healthy aging in our province by building a provincial network that connects the sector's organizations so that they can collectively advocate for healthy aging on a provincial level, to share knowledge, and to create functional relationships with both one another, but also with our system allies in health, housing, and other sectors. The goal is to create communities where older Albertans can be supported as they grow older in their homes, engaged in their communities, a future, of course, that we all want and benefit from. So now that you have a bit of background on this work, let's look at the current state of the sector as has been shared with us by the senior services sector. So as part of the community development approach, we've hosted community conversations to hear firsthand from community-based senior serving organizations about their current state. The most recent community conversations we hosted was on how organizations are continuing to serve seniors during the pandemic. Participants were invited to attend virtual conversations and complete a sector capacity survey. Both of these revealed to us the information that I'm going to briefly share with you over the next few slides. We won't have time to go in depth into the findings, but you can access a copy of the report on the Core Alberta site. You might find it useful in your work to know a little bit more about how community organizations are faring right now. At a glance, you can see the current state of the CBSS sector, along with how service providers have described their work. What I'd like to highlight is that many organizations felt similarly, which made it easy to identify some key trends in the state of the sector. I encourage you again to read the report, as there may be things there that might influence your work and your approach to engaging the sector. I should also note that the community conversations we hosted was not just a time for people to discuss the challenges that they're facing. It was also an inspiring time where service providers could hear examples of community innovation from each other. We really love to hear the success stories from individuals working in community and hearing how agile and responsive community is to the needs of those they serve. And that's, I think, really, I always call it the secret sauce of community, is the ability to be so agile and responsive to community, because it is for community by community. A lot of grassroots volunteer-led community organizations that are on the ground responding to, in real time, the needs of people that they live side by side in their neighborhoods, right? However, let's address the issues that have been raised to us, along with some of the gaps. The top 10 issues that emerged reveal what is being amplified and further exacerbated by the pandemic. If you break the chart up in half, you can see that the first 5 items describe the decline of older adults' physical, mental, and social health, which tangibly impacted the complexities that older adults face in the second half of the list. What follows this list are the gaps that organizations are facing, namely in capacity and funding. The detailed report expands on some of these challenges. I also have a chart to share that references funding sources for community-based senior serving organizations. As you can see, organizations had the opportunity to share more about their funding sources and projected levels of funding and resources. This snapshot is helpful to us as it displays the varying levels of government funding, something that is poignant as we are working with 3 levels of government, and community organizations are often sourcing funds from a wide variety of sources to deliver their services. Additionally, we have better insights on the health of the sector and advocate for more consistent and sustained funding, seen in how it impacts programming and services. I'll share a little bit more about Alberta's unique landscape when we discuss our strategic objectives for the sector. We wanted to share the results of this survey in the context of the Alberta Association on Gerontology's work on the policy forums. It's important that through Healthy Aging Alberta, we have the ability to monitor the health and impact of the community-based senior services sector, to respond to changes in public policy, through increased service provision, and to anticipate opportunities to work more systemically with our partners in other sectors. From the survey results, you can see why the work of Healthy Aging Alberta is embarking on is essential in meeting the needs of older Albertans, both today and in the future. Let's chat a little bit more about where we want to see the CBSS sector in Alberta. In 2019, the Community Leadership Council identified 4 strategic objectives through a thorough strategic planning process with guidance from the community. The first objective is to establish and coordinate the CBSS sector, which involves articulating the impact of the coordinated sector that can represent and advocate for the value and interests of the community-based organizations to relevant stakeholders such as government, health, and housing. It also involves the establishment of the Community Leadership Council to provide sector leadership, so that's now in place. This objective emphasizes that we are using the for community by community model as we exist in an interdependent system. Healthy Aging Alberta is the third sector, representing community supports working alongside housing and health sectors. Together, we form a strong base and foundation within the broader senior system of care. Working system to system, we now have the opportunity to have more fulsome discussions around non-medical supports for seniors in Alberta. Prior to the formation of Healthy Aging Alberta, we didn't have a mechanism to facilitate conversation systemically, along with our colleagues in Family and Community Support Services, or FCSS, providing primary and secondary prevention, alongside more complex models of intervention, encompassing all aspects of the community-based senior services sector within a broad spectrum of care for older adults. One of the activities that we're also engaging in includes the development of the Healthy Aging Framework to provide shared language and common understanding of the work of the sector. As Kahir indicated, it's really important that we have consistency in the way that we value the work that occurs in community. The advantages that we have in Alberta involve having a single health authority and the inclusion of the unique FCSS infrastructure that we have in place. The challenges in Alberta is that the work required in building towards an integrated system of community-based senior services, especially as other jurisdictions perhaps have more integrated government, health, and senior services. Right now, we're leaning very heavily on an interministerial approach with a lot of support from our sponsorship from the Ministry of Seniors and Housing to make this work progress. However, that also needs to recognize that the majority of funding does not lie within that ministry in Alberta. This foundation leads us to our next strategic objective. The establishment and coordination of the sector, we will also provide provincially coordinated, continually learning, improving, and a collaboration network, which is primarily the work being done through Core Alberta and the sector weaving work that will happen through the provincial and regional sector development work through the constellation model. There are currently over 1,200 members on Core and 18 existing groups. These groups span the province and cover a variety of issues that members come together around. The goal for Core Alberta is to provide a diverse and rich mutual learning opportunities, create inviting space for meaningful conversations and connections. And lastly, core groups are paving the way towards sector building as belongingness and confidence to contribute where contribution is fostered. Sorry, Miriam, I skipped ahead. One more. So in Core Alberta, we're going to show a quick video that spotlights some of the benefits of participation on the Core Alberta website.
It's all the growth and all the work that we've done over this past year, right? We're building momentum and we're getting recognized. And because of Core, we're able to reach so many people effectively and financially responsibly, because our presenters aren't charging us and Core does not charge to register or share. So it's invaluable in how we are sharing resources and information. And networking, there's lots of networking that goes on. You can see the chat just flying when presentations are on. People are connecting with each other, but also with the presenters. So they're able to follow up and get more specific help on specific situations they're dealing with.
Thanks, Miriam. Okay, I'm going to jump ahead a bit so that we don't run out of time.
It's all the growth and all the work that.
Oops. Okay, so the third strategic objective, as I mentioned, is really around the development of the programmatic initiatives that allow us to really respond to the needs of community-based organizations and the seniors that they serve. So the primary focus of those programmatic initiatives right now is around in-home supports and social prescribing. Sorry, Miriam, I'm going to jump ahead. So you can see on this lovely slide, we've learned a lot today about social prescribing and in-home supports from our colleagues in the UK and in BC. Probably don't need to delve into that, but we will say that Alberta is primed for introducing both of those initiatives, with some initial investment being made from our colleagues in government and in civil society. And lastly, it's the strategic objectives around advocating for appropriate and coordinated investment in this work. So as Kahir highlighted in his last slide, this work cannot occur without investment to support the delivery of this work. So we're working towards the development of a funders table to support the coordination of investment in that space. I'm going to skip the next slide, Miriam. And then we ask that you consider joining us to participate in this work. So there's some regional gatherings coming up. Miriam can jump in and put maybe some information in the chat box on that. And we really want to emphasize again that seniors are at the center of this work. And we ask that you consider getting involved, because that's the most important thing, is that this work is for community by community. And many of you today on the call are part of the community that's going to continue to build this important work. So thank you so much for having us here today, and I look forward to a very robust discussion.
All right, and so Jordana has been monitoring the questions and answers, and she's going to lead this section here. So Jordana, questions from the audience.
Thank you, Sharon. If anyone has any questions that they would like our speakers to address, you can click the Q&A button at the bottom of your screen, and you can also upvote by clicking the thumbs up button on other questions that you would like answered, where you can comment on other participants' questions if you have something to add. So the first question I see is from Linda regarding social prescriptions in BC. I wonder if all physicians would be able and willing to be involved in this. Did you consider a model in which provincial healthcare or health or social care workers would meet with every older adult, maybe 75 and above or 80 and above, and discuss needs and options and ensure that there would be a connection to this type of coordinated service?
Thanks. Maybe I'll I'll step in and offer some thoughts on this one. There's two pieces to this particular question from my perspective. One is around engagement from physicians and primary care providers. In British Columbia, we have six health authorities, including the First Nations Health Authority. And in order for us to mobilize this, we presented to the executives of all of the health authorities. And we work closely with the health authority chief medical officers to help implement some of this. So there's a particular health authority that has 11 social prescribing initiatives, which is championed by the chief medical officer. And so being able to identify a champion and a chief medical officer as a champion really helped to support physician engagement in this work. And ultimately, we already hearing from physicians saying this has helped our workload. and so we've seen some inherent value there. Look, we aspire to get to a place where UK, Denmark are in terms of some of the work that they do. And so, for some context, we are 3 years into the launch of our 21 social prescribing investments across the province. And so we're continuing to learn. And some of the suggestions here around person-centered care and meeting with older people, I think, will be an evolving conversation. We've found from our perspective, an incremental approach facilitates engagement and continuous learning to get to where we want to get to. So absolutely, we have a lot of work to do. But also, I think the idea of physician and primary care engagement is so important. And one way we have done this is by engaging champions within each of our 6 health authorities.
Thank you. The next question is from Marlene. What plans does Alberta have to address increasing issues with primary care services, including strategies to enhance effectiveness of primary care networks, foundational to the changes we are hearing about? I'll open it to the floor.
I can't speak on behalf of what Alberta Health or Alberta Health or primary care networks have planned. But what I can say is that the development of Healthy Age in Alberta allows us to do is to speak in a more cohesive way around the needs of older adults and the community-based senior serving organizations that work with older adults in terms of how we best meet their needs as a sector. So, for example, we have now been able to advocate to have representation from the Community Leadership Council at various health planning tables to represent the role of community-based organizations in the delivery of health system services, which has not previously been the case. So you would have, for example, planning tables working on health system redesign and, let's say, home care, where there's significant discussion occurring around transitioning to community-based care and the role of these non-medical supports and supporting that transition. And there would be nobody at the table representing community-based organizations that deliver a significant portion of those non-medical supports, whether it's Meals on Wheels or supported transportation or caregiver supports. And so the development of Healthy Aging Alberta allows us to participate and represent that entire system of non-medical supports in a way that's never occurred. And so when it comes to primary care networks, my hope is that the development of Healthy Aging Alberta will allow us to advocate and work in partnership with other systems like primary care networks in a new way. In terms of the work underway to address concerns in primary care networks, I can't speak to that specifically, but I think we are better positioned to work with our colleagues in those systems than maybe we have been in the past. I don't know if others want to maybe jump in to speak to concerns in primary care.
Dr. Essam, how has that worked in the UK with primary care and working with the community-based serving sector?
How does it work? it's a process. I mean, it's all about integrating the link workers into the conversations, bringing them into the multidisciplinary team meetings. I think the pandemic sort of put the brakes on some of that, unfortunately, because there wasn't that sort of dropping in and sort of having conversations so much. But it's starting to pick up a bit more now. It is critical, because the way we're organising primary care now with primary care networks is we're positioning primary care to really influence population health. So we're positioning primary care practitioners to realise that they have a responsibility, not just to the people that are on their list, but actually to the population that they're serving. So getting the link workers more and more integrated within the primary care networks enables the primary care doctors to start to think outside of the box how they might use their resources in a more preventative, holistic kind of way in partnership. As I think I said before, it's not about getting the GPs to do all of those social health determinants, but to embrace things so that they're actually giving credibility to the services that are offering that sort of service. You know, that it's at least as important to get your housing and your debt sorted out as it is to get your diabetes controlled. You know, actually, if you don't do all three of those, you know, you're not going to be well. So I don't know if I've answered the question, but it's a the more we include social prescribing in our development of primary care and our development of community, the more buy-in we get from the different people within the different parts of the sector, and the more we bring GPs along with us. But you just have to keep doing it. And the funny thing is, you will find in some areas that people don't get it to start with. You know, they're what you call your laggards. You will find people within all of those areas that do get it, and it really doesn't matter what their job description is. If they get it, if they're an enthusiastic receptionist or a practice nurse or whoever they are, that they get it, they start actually making the connections, encouraging the referrals and telling the stories, then it gains that momentum. I don't know if I've answered that question or just seized the 3 minutes I lost earlier.
Thank you very much. Here, how's that working in BC with the primary care networks, that connection?
Yeah, so my response also kind of leads into a question in the chat from Don as well. Is in BC we're just in the process and implementing primary care networks. But when I think about the challenges and access in primary care, there's two things that come to my mind. One is, amongst others, but two main ones that we've heard. One is challenges and access to primary care sometimes are based on structural systemic barriers that do not adequately meet the cultural, socio-political needs of people that are looking for services. So there's a systemic structural piece that needs to be addressed. I think more relevant here is, there's also capacity challenges, and we know this. But I'll also say there's capacity challenges in the community-based services sector. We see the downloading, the referrals to the community-based sector. And so we have the social community sector that has capacity challenges. We have the healthcare primary care sector that has capacity challenges. Continuing to act as independent silos is not going to achieve an outcome that is really sustainable. And so really integrating the two sectors together in a way that's collaborative, in a way that meets people where they're at, and in a way that ultimately leads to resolving capacity issues, which are not only funding, but it's talent as well, people. And we know the labor market challenges that are currently being faced across different sectors. But it's when we collaborate and when we look at how to best meet people where they're at, where that really helps us to look at future capacity issues. Look, if we're expecting to see dollars saved and enhanced capacity in 6 months or a year, that's not going to happen. right? But we need to be invested in this in a multi-year strategy because our systems, as they currently are enacted, have perpetuated this these challenges and these access barriers to access. And so at the risk of sensationalizing this idea of partnership and collaboration, from our perspective, this integrated support of continuum of care is what's really, really important.
Jordana, other questions? Thank you very much. Excellent answers.
So the next question comes from Jennifer. As a health educator, I'm interested in hearing your thoughts on how post-secondary institutions might contribute besides integrating the information into our courses. I'll open it to the floor.
So I can start off, and then if any of your colleagues have any further thoughts. So look, the number of placements that we've had with students across varying fields in community in our work just broadens the perspective of future graduates. Being embedded in community, seeing how this work is tangible, seeing the impact it makes on the quality of life of people, and I can just speak from United Way's perspective. We've had about 15 placements in the last year, and we've hired on half of them because they've understood, they want to be in community, and they understand that work. Now, there's ways to embed some of this in curriculum, so future graduates are aware that this is important work, but also socializing this in real time to people we found to be impactful. So I'll start off there. For those of you that don't know, there was a recent textbook that was published called Health Promotion for Older Canadians, and in that book, it really looks at the different social determinants of health and innovative practices to support that. So really advancing the literature, advancing the curriculum, advancing the work placements are some examples that we've had here in BC.
Dr. Essam, how are you incorporating learners in your system?
It's a process. I think we really need to get down into, we have a sort of a tier in the UK, a sort of 16 to 18-year-olds that are in an area where they've left school and they're sort of studying health and social care and sort of public services generally. I think that is the seam that we really need to get to actually teach them the importance of the social health determinants, so that whatever area that they go into, whether it's police or nursing or occupational therapy or whatever it is they do, they remember the joined upness, because the problem is that education into a particular bit is quite siloed, that we have these sort of professional colleges of this, that and the other, and they don't really often integrate even different college members. So we need to get at them early so that whatever stream they go into, they realize that the specialist bit that they're looking at is only a part of a much bigger picture, and that they think real people. When I went to medical school, I remember there was only one consultant that actually thought about the patients not in the hospital. And she used to say, now, look for clues, look on the locker. Have they got any get well cards? Do they matter to anybody? Look for clues, because you're never going to have the privilege of going to their home to see what their life is like. And you need to have some idea as you're treating them. But she stood out. All of the others was just a case of this and a case of that. And I think there is still an enormous amount of that. So yes, get to people early whenever they want to be doing a peoply kind of job. Get to them early and teach them the different things that make a difference to people. And if you can get them in shadowing any social prescribing or community groups, just kind of wreck them so that they know that people are made up of much more than their medical conditions or their housing situation, that the whole thing really matters. I think if you can convince them of that by the time they're 18, then they will never forget it.
Maybe I'll add to that because that's a great jumping off point. So often we have students who come to us at SAGE in Edmonton and their entire curriculum has assumed that seniors will live in long-term care centers. And they're surprised to learn that the majority of seniors will never make their way to facility-based care. And it's a bit of a surprise. And so we have an enormous amount of pressure in community-based organizations to facilitate practicum placements because it's an important part of their learning. And yet post-secondary education institutions really struggle to facilitate that opportunity for learning in community. And so I think about Healthy Aging Alberta for the first time having this coordinated infrastructure to work with post-secondary to facilitate community-based learning opportunities in a more systemic way. But to take pressure off of community also to facilitate research. So we also get calls, I'm not exaggerating when I say at least once a week, from somebody who wants to facilitate research in community, to facilitate the process of recruiting research participants. The list goes on. And the push-pull relationship between researchers and community-based organizations and participants in research studies. So Healthy Aging Alberta, inspired by the work that Kahir and his colleagues have done in BC, we know we can play a role in brokering that relationship. So we look forward to exploring that. And then finally, the whole piece around workforce planning. We are inspired by the work that ASHA has done to work with post-secondary institutions to help shape how their workforce is developed to meet the needs of housing operators. And similarly, we need to do the same to support the workforce needs of community-based organizations. I don't know, Irene, if you have some thoughts to maybe add to that. I know the next session AAG is going to do is on workforce planning, but maybe we can give a teaser on that.
I actually have a question here and I'm going to start with Irene. What excites you most about the opportunity for creating more integrated services for older people here in Alberta? You know, what excites you most about creating those services? Irene, what about you?
The whole system change and actually meeting the needs of people in new ways and meeting them where they're at and everything that's been talked about. We have discovered that in the housing system long time ago, and we see people become well just with all those supports of having someone to talk to, having good food, having somebody care about what their day is like. And the fact that we've been talking about this for 30 years and nobody's gotten it, and now we're here, I couldn't be more excited on behalf of, you know, all of us who will need this service one day.
Kahir, I'm going to go to you next, Karen, and I'm going to end with Dr. Essam.
I'll just share a personal story, and I think the story will illustrate my excitement. I had the honor of being raised by my maternal grandmother. About 10 years ago, she had a stroke and had vascular dementia. Now, my grandma and I had the privilege and honor of being her primary caregiver for the first year while she was at home and her dementia advanced. We had, you know, such a great clinical care team. You know, she had great doctors, but there were three things that really impacted her self-esteem, that really impacted her overall well-being. One, she was a lover of saris. So for those that don't know, a sari is a traditional Indian garment. And she had 400 saris. So she never wore the same sari twice in 1 year. Saris are complicated to put on. Even though I tried, I could not put on a sari. And that agitated her. She reverted back to her original language of Sindhi, which none of us in our family knew. And three, she wanted to go to her place of worship for prayer. We found a local community organization where every Friday, 3 women would come over, help her wear her sari, speak to her in Sindhi, and take her to her place of worship. And I am convinced it was that intervention and support that not only prolonged her life, but prolonged her quality of life. So that support in combination with her primary care support is what, in our family's humble opinion, extended her quality of life. So that's what excites me.
Excellent. Karen.
I think, oh gosh, where to start? I am inspired by what Dr. Essam said earlier about the idea that we can get to a place where our system recognizes the right provider at the right time, and the work of our colleagues right across the system is appreciated and respected and invested in. And so community-based organizations, I think that often the work that occurs in community is undervalued and maybe not recognized in the way that it could be. And so I'm so encouraged and excited by our conversation today, because I see that we're getting closer to that time. I'm going to take that away today, that we're inching closer towards that day here in Alberta, and that it is possible. And I'm excited for that.
And Dr. Essam, last words.
You know, what excites me about Canada is that you have a phenomenal recognition of the resource in community. And you are so eager to release the riches of your communities on behalf of the precious individuals in it, which is why social prescribing, bringing it to Canada, has been just lighting the blue touch paper and watching the flame just track right across every province, which is absolutely phenomenal. And I am excited just being with you today and interacting on the chat a little bit, getting that sense of we will do this, and that sense of determination, and that acknowledgement that actually without hope there is no future. And for each of the people that you are reaching out to, what you're doing is you are getting on their page and discovering what hopeful looks like, what future would ideally look like, and you're getting in there to make that happen if at all possible. And that is so precious, just mobilizing things around, and a willingness to shift resource, to change the way you do things, to say, well, actually maybe we could do things better. You know, you are phenomenally innovative, creative, collaborative, rich people, and the heritage is full of so much, you know, and I'm count it an enormous honor to be rolled in as in some kind of matriarchal fashion as often as you'll have me, to try and help you make the very best of the very beautiful nation that you are.
Now, we're right at half past. So thank you to our speakers. This has been absolutely wonderful. And thank you for attending this seminar. The next webinar is June 15th, Improving the Work Environment for Senior Services Workers. So check out the AAG's website and get registered for that. Finally, you'll be receiving a survey asking for your feedback regarding this webinar's experience, its value to you, the priorities that you see for Alberta's transformation journey. Your input's very important for improving the webinars and informing action plans in the future. So please fill out that survey. And thank you very much. This was fabulous. Thank you to our speakers.